Just a few housekeeping rules. Can you please turn your mobiles on silent or switch them off? Toilets are in the main reception area foyer, first floor. There are no fire alarms expected during this time. Thank you. Bapio conferences are becoming more and more popular, and for the last few years, we have been adding Friday to the main conference, which happens on Saturday and Sunday. And Friday is more like a pre-conference workshop or symposium, generally talking about important issues or collaboration. And today is no different. We are talking about Indo-UK collaboration and international collaboration. And some serious topics are going to be discussed and some serious announcements are going to be made. So it's going to be an interactive session. There is plenty of opportunity for panel to participate. Without further delay, because we are already late, which is not surprising given that it's Bapio conference, I invite our morning chairs, our president, Dr. Ramesh Mehta, and Mr. Keshav Singhal, Professor Keshav Singhal, to take the session forward. Thank you.
Good morning, ladies and gentlemen. Parag, you can't say that because his Bapio is getting late. It's because his Bristol is getting late. It's the weather, all right. Yeah, we need to have some excuse to blame somebody. Actually, it is the technology which has taken a little longer, because we are now very strict that we have learned some real good things from British, and one of the important one is keeping to the time. And that's what we normally do. However, although because of the audio visual there has been some delay, the good news is it's working absolutely fine. So we are going to have a real good session today. Parag, thank you. Thank you for your team for organizing this, and thank you for the good hospitality. Everybody had coffee and breakfast? Okay, we are ready to go. Now this Friday conference that we've been having is a collaboration with Health Education England. And I'm grateful to Jade here and Jonathan for being our partners in organizing this. This is a crucial issue that we are going to discuss today, and that's why the collaboration with Health Education England is so important. Now, crisis in human resources has been described in various ways by different organizations, including WHO, which say that it's the most pressing global health issue of our time. WHO estimated in 2006 that there is going to be shortage of 4.3 million healthcare workers globally. This was 2006, and I think probably we can now say it's probably the shortage is going to be almost 10 million globally. Healthcare workers are important, but the healthcare workers have to be competent, so their education and training is also equally important. And that's why we decided today to discuss about the issues and the solutions. I'm really pleased that we have some top-notch people who deal with human resources here. And I'm delighted to welcome the Chief Operating Officer of General Medical Council, Mrs. Susan Goldsmith. Now, you know, GMC, of course, like any other organization, can have problems, and we have had issues with GMC. But at the same time, GMC, and this is my personal experience dealing with GMC, that they are very open and transparent and willing to listen to us and willing to find solutions with us. So we are grateful not only for your presence, but to GMC for being transparent and able to listen. I know, like any organization, you have restrictions, you can do only so much, but you are trying to do your best. Jade, of course, we are absolutely delighted to welcome. He is our partner. He is also Director of Global Engagement for Health Education England. Now, HEE, that's Health Education England, is part of NHS, part of Department of Health. And I think the government, for whatever bad things they do, the good thing they have done is that they have a special department for global engagement. And Jade chairs that. And the big advantage of this is not just UK, but the international issues to be discussed. And I think Jade hopefully is going to make some special announcements on behalf of the Department of Health today. So let's kick off now, and I'm going to invite Susan, and she's going to talk about challenges facing the global medical workforce. So we will have 7 minutes, but Susan is VIP, so she can have 8 or 9 minutes. And then we will have a panel discussion. In our panel, we have Jonathan Brown from HE. Jonathan, over. Oh, this is an important announcement. This conference is being webcast live now globally. So there is okay. So the link will be there in a minute, and it is being webcast. So I think that's very good. Okay. Another important person we have is Ambassador Dr. Virendra Paul. Dr. Virendra Paul was Deputy High Commissioner for India in London for quite some time. He is based in Geneva and he works with WHO. So he's on Skype now. He's listening. Hello Virendra, you alright? Okay. Thanks for joining us. And welcome, Susan.
Thank you very much, and it's a real pleasure to be with you this morning. So over the next 7 to 10 minutes, what I'd like to do is to focus on 3 key areas. Firstly, I'd like to reflect on workforce shortages on a global level. Secondly, I'm going to talk about what GMC's data tells us about the changing workforce in the UK. And then thirdly, I'll offer some broader thoughts on areas where I think the system needs to focus in order to tackle the significant challenges now facing the UK medical workforce. Now, the GMC doesn't have an explicit remit around workforce, but we do influence supply insofar as we have an oversight of both undergraduate and postgraduate education. We approve new medical schools, and of course, we register doctors onto our register. So this is the scale of the challenge. The World Health Organization, the figures can vary a bit, but the figures I have listed the shortage of 4.2 million healthcare workers worldwide. And whilst developing countries suffer from a so-called brain drain, if you like, with their homegrown doctors migrating to work in countries that offer better wages and better living conditions, a number of developing countries are also reporting doctor shortages, particularly in rural and underserved areas. And to date, those responses to those issues have been very short-termist, really focusing on the symptoms rather than the root causes. Now, I've just come back from Dubai with the biannual conference of the International Association of Medical Regulators, and it was interesting to hear some of those examples really in practice. As you can imagine, workforce shortages were a key part of the agenda. And we heard from Brazil, and they tackled their workforce shortages by recruiting a whole load of doctors from Cuba. But the consequence of all of that is that their workforce is now made up of, to the tune of about 50% from overseas trained doctors. Equally, we heard a fascinating presentation from Jordan, where 1/3 of the current population is now made up of Syrian refugees, but not living in refugee camps, but actually outside of those camps, and 90% of them are outside of the refugee camps. So you can imagine the impact that that has on the infrastructure generally, particularly on healthcare. And that led to a whole discussion around the ethics, actually, of developed countries recruiting from those types of countries that really require their homegrown doctors. This was the caption that really interested me and really sort of underlined some of the incentives and the extent to which countries and governments are going to recruit their workforce. But the other point is that it does also illustrate how difficult it is for regulators who are grappling with the issue of how to maintain high quality standards whilst also helping employers and governments to attract and retain high skilled medical professionals. And often these imperatives can pull in very different directions. So let's just turn to the UK workforce. All of us know that the supply of doctors is simply not keeping up with the demand. There's not enough doctors joining the profession. There are too many leaving or indeed working part-time. The latest data from NHSI shows that there are 108,000 vacant posts across trusts in England, and that's a 15% increase. So this is Q1 2018 data, 15% increase from Q4 2017, which is, I think, quite phenomenal. Whilst our data shows that over the last few years, the number of doctors joining the register has been really, really stable, clearly demand continues to rise, with the situation being particularly critical in rural or coastal areas where there's an older population, often with multiple morbidities and a scarcity of medical professionals. We do know that there are problems with the current inflexible approach to postgraduate education and training, and it makes it very hard for the profession more generally to adapt to a changing population and service needs. And part of the problem is that training from overseas or from non-training grade posts is not always recognised. We're working hard to address those issues. Now, of course, our health service depends on and benefits enormously from the contribution of both EEA and IMG doctors. In 2017, a quarter of licensed doctors on our register were IMGs, nearly 1 in 10 from the EEA, meaning that overall 1/3 of the UK doctor workforce trained abroad. And this is particularly pronounced in certain geographies. So in Wales, for example, 3 of the 7 health boards constitute over 1/3, the IMGs constitute over 1/3 of the medical workforce. And here's what else we're seeing, some quite complicated graphs there, but some simple messages, and they are that applications from IMGs have started to escalate rapidly. We've seen almost a 50% increase in the first half of 2018 in those applications. And we're seeing increases in applications from geographies all over the world, but particularly India, Pakistan, Nigeria and Egypt. Now Brexit, the number of live vacancies in the NHS are obvious explanations for that. It's a very dynamic picture. However, our current registration processes for IMGs are very time consuming and our systems are at a maximum capacity. So we are investing very significantly in that capacity. We're building new Plat 1 centres, for example, in countries of high demand like Nigeria. We've actually just opened our first Plat 1 centre in Edinburgh and are increasing capacity for Plat 2. In contrast, however, to IMG applications, the second chart shows that the rate for EEA applications has significantly slowed. Although I don't really think that we're seeing the true impact of Brexit in those numbers yet. Either way, it's really important that we understand what these trends are telling us. So what impact is this having on the front line? We know that significant pressures within the healthcare system are having a profound and detrimental effect on the workforce. In our 2017 report, The State of Medical Education and Practice, we actually talked about the workforce being at a crunch point. But with rising pressure and demand continuing to outstrip supply, actually I'd probably say that the profession is teetering on a cliff edge. Our recent research, what it means to be a doctor, and the findings from the National Training Survey certainly seem to support this finding. Severe pressures in the system are affecting services, training environments, and the ability of doctors to do their jobs, with significant numbers of the profession reporting burnout, intention to reduce hours, retire early, or leave the profession in other ways such as moving abroad. Now I'm going to leave it to Jed to talk about the government response, but suffice to say we have been closely involved on a number of these initiatives, GP international recruitment for example, and will continue to be involved going forward. But thinking about what we can do at the GMC as part of a wider systems response, these are some of our thoughts. We have also replied to the call for evidence for the new workforce strategy and 10-year NHS plan. But first of all, we want to make it easier for IMGs to work in the UK. So this year, for the first time, we have started to accept the OET language proficiency test as opposed to just IELTS, which we hope will increase options and flexibility for doctors keen to work in the UK. We're extending our welcome to UK practice sessions for doctors who qualified overseas under new to UK practice and hope to target 80% of those by 2020. Specialty doctors make up 1/3 of the acute workforce. But face particular barriers in accessing vital jobs that are only accessible to those on the specialist and GP registers. We want to better understand the motivations of this group of doctors, and so we're exploring how we can collect some of those views and experience. But equally, we want to explore how credentialing and our flexibility reforms might provide important recognition for their training and experiences that may not as yet be fully recognised. Turning to doctors from the EU, although we think we have a way forward agreed with the government, on a hard Brexit it is possible that those doctors will be treated as IMGs. Of about the 2,000 EU doctors that apply to work in the UK, 1,300 of those apply to go onto the specialist register, and that is a hugely time-consuming and bureaucratic process, often taking up to 18 months and over 1,000 documents. So we need vital reform of our equivalence route to the register. And then finally, we believe that PAs and medical associate professionals can help to fill vital workforce gaps and would benefit enormously from regulation. So, in summary, I think we need a paradigm shift in the way we approach the issue of workforce. I've laid out, and I've run out of time because I've got somebody sort of indicating me from the back, I've laid out the areas that we think as a system we need to focus. I know Jade is going to talk more broadly about that response, but I just say that no single organisation can deliver on this, and we at the GMC think we have a very important role to play by bringing our ideas, data and insight, as well as our regulatory toolkit to the table as part of a systemic response to a national challenge. Thank you.
Thank you, Susan. I'm sure that is going to generate a lot of questions later on, particularly about your flexibility in terms of registration, retention, and so on. It now gives me great pleasure to invite Professor Jed Burns, Head of the Global Health Exchange for UK, to come and tell us how we sort this problem out. Professor Burns.
Thank you. How do I move on with this little machine here? Ladies and gentlemen, I'm really deeply grateful again to Ramesh and the team for inviting us and for putting together this morning. I can't tell you how timely it is. I'm very pleased to announce that on Tuesday, we will be launching the NHS's first ever global workforce engagement strategy, which has taken an awful long time for us to develop. And it's very timely in several ways, really, but not least of which that I'm following the GMC as a form of response in the knowledge that this strategy is to be published on Tuesday. What I'm going to try and do, and I'm sort of processing a lot of what's just been said, is try and respond to some of those things that have just been said. You'll notice that there's a figure on the left-hand side here, it's slightly blurred, which says the global health workforce gap to reach 18 million by 2030. My own team smile an awful lot at the WHO's figures about global workforces. They appear to change second by second, and every time you ring them up, they give you a different date and a different number. But what we do know is there's an awfully big deficiency of workforce worldwide, and it's not getting any better. And without any question, unless we similar to climate change and to AMR, global healthcare workforce is one of a handful of major threats to the globe over the course of the next several decades. We also know that the global movement of healthcare professionals between countries is not decreasing, it's actually increasing. We are aware of the fact that many of the traditional siloed professions, the walls of those professions are becoming greyer, and there are more healthcare professionally related groups and professions that are coming on board: physicians associates, advanced nurse practitioners, healthcare navigators, whichever way which you want to put it, clinical officers, who have overlapping skills with traditional siloed workforces of doctors and nurses and the more traditional allied health professionals. So the situation is extremely confused at the moment. We are also aware that the NHS is not immune to these workforce shortages. The most recent data suggests 45,000 active adult nurse vacancies in the UK. There are 8,000 active medical vacancies in the UK, but we believe that number to be far, far higher, because in many areas, some of which have been mentioned, the lack of ability to recruit medical staff has resulted in the complete withdrawal of any recruitment process. So really we face a crisis in terms of the match between workforce and the demand for healthcare delivery like we haven't had since 1948. Now, I'm going to stop there, and I'm going to say what I say and have been saying for the last couple of years, and ask a question. And I'm pleased to see Umesh here, actually, who also repeatedly asks the same question, which is, why in the largest, most well-respected universal health coverage system in history, with a workforce of 1.3 million, which is based on an educational profile for training the best healthcare professions in the world, and a demand externally for people to come and train and work in the NHS, do we have 45,000 nurse vacancies and 20,000 doctor vacancies? It couldn't be more silly. And responding to the brain drain issue, our new strategy is very much focusing on a co-development approach based on education. Health Education England, at its ethos, is about generating the right workforce at the right quantity and quality for the delivery of healthcare within the NHS. But underpinning that ethos is an educational ethos which recognises that the way in which the NHS offers value for money is it creates clinical learning environments which are unparalleled anywhere else in the world. And all of us who've been subject to clinical environments know that those environments are predicated within a culture where everybody teaches everybody else and everybody learns from everybody else. It's on-the-job clinical learning. So the vision stated in our new strategy, and I can't read it because it's blurred and I'm blind, so excuse me a second, is a world leader in healthcare workforce development and an increasingly flexible NHS workforce with the capacity and capability to respond to the future needs of patients and the public and provide integrated whole person care. and underpinning that, a mission which is to strengthen the healthcare workforce globally by embedding global learning and training through placements and exchanges, while working with international partners to share NHS expertise through technical collaboration. Now, effectively, the new strategy will lay out 3 priorities, and they can be loosely termed inward migration, outward migration, and technical assistance. And what I want to do is particularly focus on the inward migration side of things, because that's really is the focus of this session this morning. But I also want to mention the other 2, because without doing the other 2, the NHS cannot ethically take its position as a leading educator of global workforce. Okay, sorry, these slides have... What's the difference? So just the underpinning principles, what we want to do in all of our strategic programs is be absolutely ensure that there is a co-development element. There is no longer any, well, let's put it another way. The UK has a major responsibility to recognise its ethical responsibility to global workforce. We have to state, and we have to be honest, that for the last 70 years we've been extraordinarily inward looking on this. We have spent a significant amount of time brain draining other countries without consideration of the development of universal health coverage within the countries of origins of those individuals. We cannot any longer justify that. Our position in global politics at the moment has seen better days. We understand that. And we definitely need to do something about that to generate much stronger relationships with our friends who've been friends of ours, despite the fact that we've not treated them terribly well over the lifetime of the NHS. Any programme that we will sponsor and get involved with must have a degree of transparency and a degree of quality that is acceptable to the NHS population and to the existing workforce. We will not do any inward or external migratory programme that hasn't got an evidence base and doesn't continue to be evaluated. And that any programme that we undertake has to be sustainable. It hasn't got to be a gut reaction to a particular focused workforce deficiency where we pay through the nose in order to get staff in on a short-term basis. We cannot no longer afford to do that. So, where are we currently working? Well, the strategy will reveal that we currently have quite a big global spread. We have, again, on the 3 basic principles, our inward migration at the moment is not quite matched with our external migratory activity, which is not quite matched with our technical assistance activity. We are technically assisting currently 11 countries across the globe. Just to run through them very quickly, if I can remember them: the Philippines, Malaysia, Thailand, Myanmar, Brazil, South Africa, Mexico, China, Kingdom of Saudi Arabia, Egypt and Greece. There we are, we've got them all. What we are doing is we are working with those governments and attempting to utilise our experience in health system strengthening to look and analyse their current systems and try to get them to invest in areas which are going to produce sustainable improvements in healthcare indicators within their own nations. In terms of external migratory activity, we currently have underpinning a series of programmes which are mobilising NHS staff to go and work and learn predominantly within the low-income country settings, and there are several countries in East Africa, Uganda probably being the biggest at the moment, together with South Africa and some in South East Asia, where we're increasingly supporting staff to go and learn for a wide variety of reasons in these low-income countries. In terms of internal migration at the moment, and I'm going to come on to this in more detail in a minute, we are very much focusing on Southwest and Southeast Asia. The reasons for that is that there are government-to-government pushes about developing much closer relationships, particularly with India, which is the focus of this morning's conversation. Sorry, these slides are not working properly, are they? But hey-ho. Okay, so I'm just going to run through, without using the slides, the specifics about doctors. So thinking about the basic principles of what we're attempting to do, what we want to be able to do is we want to be able to utilise at heart the NHS as a clinical learning environment for the betterment of global workforce. So to reduce that 18 million global workforce gap without robbing individual countries of their workforce to such an extent that their own universal health coverage systems become disempowered because of it. And so we have settled on a series of programmes which are based on the fundamental principle of earn, learn and return. And what we mean by that is the identification of countries who want to work with us, who can send healthcare staff, including doctors, to work and learn with us for a period of time, and us to empower them to return to their country of origin with increased and enhanced skills to improve the healthcare of the population from whence they came, or from populations who have challenges but are not in the UK. And this is actually quite a difficult thing to achieve, particularly where you've got a workforce deficiency of the size that we've got at the moment. But actually, when we talk to governments about this, they can see the model, and that they can see the model as being very important. And one of the things about repeating the narrative over and over again is that the governments are waking up and saying, yes, we can re-employ these doctors if you go and train them, and we can see the benefit of doing that. Now, we have currently close on a dozen medical programmes which we're enhancing. And I'm going to mention a couple of those now because I think they're very relevant and also very India-centric. And the largest of these programmes, which we are supporting, not leading, was actually developed in Wigan, Wrightington and Lee under Umesh and Raj Murali some years ago. And the principle of that programme is that it is an educational programme over a 2 or 3 year period where relatively junior doctors will come and spend a significant period of time in Greater Manchester or Greater Manchester area and its partners, doing a clinical master's programme, delivering clinical care, receiving a qualification and returning back to India. It's a real vanguard programme, and one of the several reasons why it's a vanguard programme. The first reason is there's almost zero attrition from it. Because the pastoral care from Indian diaspora organisations in the north of England is so good that the people who come want to be on the programme and want to stay on the programme and deliver. The second thing about the programme is it is easily expandable. And one of the reasons why it's so easily expandable is that the educational component of it is transferable, and the higher education institutions that are currently working on the Wigan programme are sufficiently flexible to allow that expansion. And the third issue of it is that it started off very small, and it's a bottom-up programme, and it's driven locally by the teams. Now, because of that programme and because of the success of other similar programmes, we are working very closely with Bapio to try and develop a generic template and a generic agreement with the regulators and with ourselves to promote that sort of earn, learn and return programme for every different level of doctor. We're also working with the University of London to develop a clinical Masters of Business Administration for more senior doctors to come over on a similar programme. We have a relationship with Mexico, which is now providing us with GP trainees, and a similar relationship with Grenada in the US, but all of them are on the same earn, learn, return programmes, either under a Tier 5 or under a Tier 2 visa. We're working very closely with the Royal College of Radiologists, and in fact we've managed to get the Royal College of Radiologists to increase the number of FRCR Part B examinations so that they can process radiologists who we can give an earn, learn, return offer to come and work in the UK at the end of their training, and that has now become government sponsored within India. So our intention is to remain ethical and to create a turnover process which utilises or puts the NHS back in the position that it should be as a world leader for the education of healthcare professionals. People want to come and work and learn with us. Some people undoubtedly will stay. But actually the numbers that we're talking about at the moment and the way in which we ought to think about this is not about workforce shortage, but about the fantastic opportunity that the UK is sitting on in terms of its education, and turning the minds of our provider organisations to recognise that those vacancy slots are an opportunity, not a downside to their business. I'm extremely grateful to Bapio, I'm extremely grateful to Ramesh. They've been enormously helpful in our support. We could not have been producing this strategy on Tuesday without your input. We simply could not have done it, and you will see when you read the strategy, hopefully you read it sometime this week, you will see the influence that this organisation has had on the way in which we are thinking. We're determined to deliver on our internal and external and technical assistance migratory programmes to expand. We're determined to significantly invest in those, and we're determined to do them on a co-development basis so that it benefits the NHS and it benefits global workforce. Thank you.
Jade, thank you very much. You've been very kind. I think most of you will know that Bapio has partnership with HEE now, and it's an important thing, you know. The moral issue of migration is critical. So whole world is short of healthcare workers. Are we going to pinch because we are rich from the developing or underdeveloped countries and use them at the cost of their healthcare? It's an important issue. So when we agreed with HEE to assist with sort of recruitment of doctors, we had two conditions. And the first one was that they must go back. So it should not be brain drain. And the second one was when they come here, they should be not only looked after properly, but they also must be trained properly, so that during their time here, while they are helping the NHS, the clinical work, they also get better doctors, and then they go back and serve their own country. I think the new strategy that Jade has just announced, I think we are fortunate that the new government strategy has been announced at the Bapio conference. So thank you, Jade. Well done. Susan, thank you very much. GMC, as I said, has been helpful, and the three important things you are planning to do. We have agreed to assist with the policy, and the government has to change the regulations, because as you said, these regulations have been archaic and they need to change. So your hands are tied at the moment unless the government takes initiative to change the regulations. We, as I have said to you before, Bapio now has a healthcare policy forum, and we have a lot of contacts with MPs and lords and politicians, and we would be very happy to assist in changing these regulations. Now, Virender is online, so he's getting connected on the video, yeah? We are going to have a panel discussion, and I'm going to invite, we have Dr. Pradeep Kumar Shah. He has come all the way from Calcutta, Bhaloachi. So he's professor of Psychiatry and Director of Institute of Psychiatry in Kolkata. So may I invite you here to be part of the panel discussion. Jonathan Brown, I think Jonathan is the Chief Operating Officer for the Global Health part of the HEE. So Jonathan, please come along. Ambassador Virender Paul will be on video at the moment. Sharad Gangadhar is a consultant oncologist in Bath. Naresh is not here, is it? Naresh? No, okay. So it's 10:30 now, and we have got 1 hour. I think we got good time. It has to be very interactive. So please keep your questions, keep a note, write down. There will be an opportunity to each of you to ask questions and discuss the issues, and of course comment, and if you have any suggestions or solutions, please feel free to do that. So Keshav is going to start off with his comments, and then we will get the panel to make some comments.
So I'll just give a very quick experience of our exchange program in Wales. Now, Wales is a small nation, and we've only got 6 health boards. So 3 years ago, we approached the government, Welsh NHS, to set up an exchange scheme under the MTI program. And I believe this is the first time we actually looked at the vacancies on a national basis, on all Wales basis. And we went into agreement with all the health boards in the Welsh NHS to recruit these doctors. Recruit means recruitment for training, not for settlement. And we were very clear that they will have to go back after 2 years. And they would be coming here for 2 years at a ST3 level under the MTI program with absolutely equal in terms of service, salary, etc., as any local graduate. The program has been very successful, so this is the 3rd year it's going to run. We've been interviewing in Delhi, Bombay, Jaipur, and so far we've recruited 100 doctors, out of which 45 are already in place. And our estimate is, the health manager's estimate is that we've saved £3.5 million in locum costs so far. There are some snags, and the snags are that a number of organizers, the employers feel that they are a pair of hands, and training is not high on the agenda of some of those trainers. So we have now made sure that we are going out to them and saying that their trainees would be withdrawn if they are not provided proper training. The trainees know that they need to go back. The trainees, however, get a very structured 2-year program of training, so they are very happy. And we have assigned them mentors, we have assigned them buddies, but more important than that, they get a very comprehensive induction before they come in terms of cultural induction and support from the local community, local Indian community across Wales. So I think it's a win-win program, but as has been mentioned, there's a cumbersome process. It takes nearly 1 year from the time of appointment to the time they actually come into UK. And I think that needs to be speeded up because a lot of them can lose interest waiting for this to happen. But I think going on from the comments made earlier, it should be a two-way street. So not just we are getting the doctors from India, but our graduates, our postgraduates should have the opportunity to go to India on a placement and learn what is best out there. So I think it's a very good program, and Bapio is proud to have started this. Thank you.
Hello, this one. Oh, Virender. Good morning. How is Geneva? Virender, can you hear us? Virender? It's good to see Gandhi photographs behind in the background. Virender? Can you hear us? Oh. Oh, he's saying something. We can't hear. Virender, we can't hear you just now. Technology. Are we ready?
Speakers are muted.
Yeah, yeah. So I've got you on the screen on the video, but we'll do audio on WhatsApp. Okay, so stay on the phone.
Let me know when my turn comes. Okay.
No, it's not coming out. Should be able to. Let's try.
So this is the problem. Do we think robots can replace doctors, the human beings? Because this technology, so robots could have problems. So it is important that human beings continue to be healthcare workers. can't leave it to intelligence, whatever is called.
Yeah, I can hear you. Good.
Virender was very keen to come here, but he was stopped because one of the ministers from India is there in Geneva today, so he had to follow the government of India rather than Bapio, unfortunately.
WhatsApp is better.
Okay. Yeah.
You are very clearly audible. Yeah. And I hope I am also equally audible.
Yeah, carry on, please.
Hello, Virender. Can you hear us now?
सर एक डिस्कनेक्ट करना पड़ेगा दोनों नहीं कंफर्टेबल या इसको करनी या इसको जस्ट ऑडियो
Yeah, yeah. Just carry on.
वो कंटिन्यू करेंगे ना वो दोनों आपस में क्लैश करते हैं
Good morning, everyone.
No, there's a lot of.
No, I think we will start with this. You can start. Yeah. So I think while we are waiting, may I request we'll start again. The Indian perspective about the immigration and the workforce shortages. Professor Saha will tell us his views.
Thank you, sir. From the historical perspective, I'd like to say that during independence in India, there were only 19 medical colleges. Yeah. From the historical perspective in India, during independence, there are only 19 medical colleges and 1,200 doctors graduates per year. And at this moment, according to Medical Council of India, there are 270 medical colleges and 28,000 graduate students per year. In 1990, the 1/3 of the medical colleges was privately run, and 57% of the total medical colleges in India was run by this private partnership. And in regarding the nursing education, in 2006, there are 1,312 nursing institutions providing the course of general nurse and midwifery, and 580 institutions offering graduate level nursing educations, and only 77 institutions offering master degree in nursing educations. And there is another category of diploma. There is an auxiliary nurse midwifery. There is 271 institutions there. But there are so many regional disparities in India. If you see the southern part of the India, 63% of the general nurse and midwifery institution was there, and 95% are privately run. And there is a serious vacancies in the public sectors. And in regard to these situations, my suggestion, sir, has mentioned me, is a part of solution. The all MBBS undergraduate doctors should be trained at least in anesthesia, and they can perform some help during cesarean section and pregnancy. And already 2 states, that is also my suggestions on behalf of the government of West Bengal and government of India. The Assam state and Chhattisgarh state, they have started non-physician workers for 3 years, those have having only the general school graduates. And the reasons of private sector could be harnessed to meet public health goals through, Sir Professor Gateborn has mentioned, the private, public and third party. I don't know what do you mean by, sir, third party, I have to ask. And the public financing of the privately provided services must be examined again and again. As because we cannot ignore the public sector. The public sector has a very important role to play, especially in primary care health services. So at this moment, there is a growth of medical and nursing education opportunities has been rapid and very impressive, but still, Madam Goldsmith has mentioned that 1 of 10 people wants to leave the service. The same situation in my country also. Madam also has mentioned that those who are having the age of 40 to 45, they want to leave the service. The same situation is also there, and that part we have to take care. And we need the robust World Health Force throughout the country, and we need the help of the training. And Professor Gateborn, few months back in our country, in my state, for the nursing training purpose in collaboration with UK and India. Thank you. Thank you.
Jonathan is the Chief Operating Officer, so all the huge big plans that Jade mentioned, he is the one who has to really ensure that things happen. So Jonathan, thank you, and your comments, please.
Thank you, Ramesh, and thank you all. It's a great privilege to be with you today. I'm not going to say a lot about the strategy because I think Jed ably explained all things to you, and it is the most exciting time to be working with Professor Byrne and thinking about how we plan and implement all those exciting new innovations. And I think in terms of the international recruitment, I would say that innovation might well be the watchword in terms of how we change the way in which we have traditionally approached immigration. And I would stress that the learning is only part done. There is a process that takes a person from their home country, from their home life, to another country, potentially thousands of miles away. And for me, the idea of planning in this area is really about considering that journey from the very seed of the idea an individual has to travel to their career as it progresses. It's a long journey, and I think we have habitually seen it as a short journey. And the journey starts with what qualification do you have? What's the visa process? What's the language training process? What's the entry mechanism? Where's the flight? You know, where's your post? What's the job? And it's been rather too short. I think we need to be really innovative about how we think about when somebody has the seed, the germ of an idea to come to another country, how do we support and help that person throughout that whole journey from beginning to end? And when they're here, how do we support them? How do we learn from the people who've been on that journey already and can share their experience and can support them? How do we institutionally, in terms of regulation, in terms of education, in terms of the NHS as a big organisational body, how can we partner together to make that journey the best that can be possibly be? And if we make the journey the best it can possibly be for the learner, and we make the learning experience the best it can possibly be for the learner, then the experience for our patients, whether they be here, in India, in other parts of the world, will be all the greater. And so, despite me being a management planner, I want to assure you that the journey that I want to plan is the one about the individual from end to end and how we approach that. So thank you for listening to me, and I just hope to hear from you now and in the future about how we improve things.
Thank you very much, Jonathan. Steve. We now have Virender from Geneva, but he is only on audio. Parag?
Yeah.
While we are waiting for Virender, may I invite Susan, please come over here. We'll take question and answers. And Jed? Jed?
No. Carry on, Ramesh.
Just do the audio if you wish.
Okay, carry on.
Okay. Sorry for this technical hitch, perhaps on our side. To begin with, I would like to thank Dr. Ramesh Mehta and you, Keshav, and Dr. Parag Singhal for asking me to join today. And as you know, I have been always very proud of my association with Bapio ever since I joined the mission in London. I bring you all greetings from the Indian mission in Geneva. I'm today here not to represent the Indian High Commission in London, as I understand my colleagues from there will be in Bristol tomorrow. Today I would like to very briefly share some thoughts on how India is engaged with the WHO to achieve what we seek to achieve in India. I had the benefit of listening to the first two presentations, but unfortunately I don't have the benefit of knowing what Professor Kalra said. But I think in the present times, the theme of focusing on medical recruitment and innovation is I believe, is very timely, as it variously applies to all countries, both developed and developing. And I can say that this thought was very well validated by the first two presentations. Coming to India, the situation in India and what we seek to achieve. I would say, as a large country of 1.3 billion people, the scale of the disease burden is correspondingly large, and the solutions, therefore, need to be equally ambitious and enduring. In India, at the national level, and also in our engagement within the WHO, we are guided by two key principles. The first one is accessibility, and the second is affordability. At the national level in India, as you might be aware of India's contribution to the UN Agenda 2030 of universal health coverage, and the initiative that was announced in late September, just last month, is called Ayushman Bharat. And under this program, the program entails health cover to 100 million families. It means about 500 million people, which means 40% of the Indian population will be provided an insurance cover of 5 lakh rupees, which is 500,000 rupees. This is a very ambitious program, and we believe that it is doable, and this is going to be the largest government-funded health protection program in the world. The second priority area for us, both in India and in terms of our engagement within the WHO, is digital health. In May this year at the World Health Assembly, we, that is India, played a leadership role in the adoption of a resolution on digital health, and this availability of connectivity technologies, the growing connectivity in India, including in the rural areas. We believe that our efforts in the area of digital health will help us reach inner areas and to make healthcare services available, all across the country. On accessibility, which is very important to us, accessibility, access to medicines, medical products, diagnostics, vaccines, devices. This is something which we have been focusing, very, very closely in India and also in the framework of WHO. We held the first global conference on this subject in November last year, and the second one was hosted again in Delhi last week. And our trust in this area is that the R&D costs and also the IP issues, the intellectual property issues, somehow we need to find a solution that they are de-linked from the pricing so that the products are made available to the common people. On the innovative side, because the theme also includes innovative solutions. Most of you are aware that the culture of innovation in India is there and is very strong in practically every field. And if you remember, in the medical school, we were taught to always remember that most diseases can be treated with common medicines, and more importantly, with common sense. And we need to use this advice as we go along. And I also remember, I don't know if Dr. Umesh Prabhu is there or not.
He is.
But I recently, he is there. Okay, I saw on his Twitter account, he tweeted a couple of days ago that the best way to save money is to stop wasting it. I think this is very important, and we should keep this in mind, including in our work in providing healthcare services to our people. I also remember a line which Parag mentioned to me, a couple of times in recent months. He said, we need to get it right. We need to get it right, and it sums it all. It sums it up, and it means that we should, in our medical systems, in our healthcare systems, we should avoid avoidable hospitalizations. We should avoid unnecessary investigations, and we should avoid over-medication. So these are the important areas we are aiming at, and we believe that